In the recent studies, there are correlation and association between eosinophilic inflammation and fibrosis in the airways. And there is another important correlation between the severity of the disease and the eosinophilic inflammation. The gold standard treatment in COPD and in asthma is sometimes inhaled corticosteroids. The problem is that at the moment there are not consistent data to demonstrate the effect of inhaled corticosteroid in COPD. Many years ago, we had just one marker. It was the inflammation derived by bronchial biopsies, but the technique is very invasive. Now we have other biomarkers. First of all, the eosinophilic or neutrophilic inflammation in asthma and COPD with the use of induced sputum. And you can find these cells in the expectoration of the patient with asthma or COPD, or nitric oxide, the measurement of nitric oxide, and more recently, the use of blood biomarkers are very useful, seems to be very useful because are very non-invasive and very simple to have by the patients. I think that the eosinophilic inflammation depends by the time of the disease, because generally the airway inflammation in COPD is a neutrophilic inflammation. But sometimes, for instance, during the exacerbation, we have the possibility to find eosinophilic inflammation, almost in the 30% of patients. And this is a very interesting data because the inflammation could determine it could target the therapy for COPD patients. The best ways to perform longitudinal studies on the use of eosinophilic inflammation in induced sputum or in the blood to evaluate the disease and to standardize, to stratify the disease, and to select the right treatment, I mean to a sort of target treatment.